Thank you very much. Thank you also for the kind invitation. Yes, I think we can move now into the second part, which deals with replacing the missing hormone. These are my disclosures. Of course, I think in this audience, I don't need to make the point that hypoparathyroidism is, of course, a disease of not one, but two missing hormones. So it is PTH, and of course, it is active vitamin D that are in the pathophysiology of this disease. And of course, the consequences, we have talked now about biochemical parameters, we have talked about quality of life. There are good data about long-term complications of chronic hypoparathyroidism in terms of renal aspects, and of course also it has been mentioned the conundrum of bone health in patients with chronic hypoparathyroidism. Just to show, this was a meta-analysis that looked into the relative effects of complications and symptoms of chronic hypoparathyroidism. And you can see, of course, here you can appreciate that the renal aspect and the chronic renal complications are very prominent in this disease. So coming now to the concept of PTH therapy for hypoparathyroidism, of course, we know that the treatment, the target is not, of course, only to optimize and ameliorate serum and urine biochemistries, but also to address long-term complications like renal complications, skeletal health, or quality of life. And this has been dwelled upon very nicely by Neil, the original guidelines, the EC guidelines, but also the ASBMR, which really made a phenotypical analysis of which patients would be the most ideal candidates to be considered for PTH therapy. And as Neil, of course, showed in great detail, and you will also hear from Professor Borslev in the next session, the wording, of course, is very important when the guideline recommends or when it suggests to consider treatment with PTH. Just to make a small historical analysis, of course, PTH replacement therapy was no new concept. So here are the studies of Karin Weiner. They are more than 30 years ago. And here you can appreciate that she used, and her group, teriparatide. And these are the first studies where they used once versus twice daily teriparatide in children. And as you can appreciate here, of course, the fluctuations in calcium, which much less with this two-day regimen of teriparatide. And even when they went far further and they used teriparatide as a pump, and they also compared this to this twice daily regimen, they could see that eucalcemia was much more possible with the pump therapy, and also hypercalciuria was much less with the pump therapy. And this was one of the previous forms of PTH replacement therapy, of course. There was another product. This was recombinant PTH 184. This was approved and used also in numerous countries in Europe, but also in the USA. And it had, of course, effects in biochemistry, but also renal effects, also skeletal effects, but it had a relatively short plasma half-life, and maybe also from a logistical point of view, the manufacturers decided to not pursue the production of this product anymore, and it was recalled in the US and also 1.5 years ago in Europe. And if we come to think now about what is the difference between these projects, I think it has to do a lot with the 24-hour profile of PTH, as is very well known, physiological PTH. And if you also give it as an IV bolus, it has, of course, a short half-time of life. And here you can appreciate teriparatide has approximately 12 hours half-life. The analogon of PTH184 has about 16, and of course through the infusion pump or long-term, long-acting analoga, it is this nearly 24 or even beyond half-time, which makes them so elegant treatment therapies. So coming now to palopeg-teriparatide, I think it has been also stressed in this Congress, this mechanism of action. So this is a prodrug which consists of this transcon carrier, and this part, which is the real drug, is linked to the carrier through this linker, so as not to be activated before it can be administered in the patient. And when you administer it and it comes to the physiological pH of the patient, then you have this removal of the carrier, which then gets renally cleared, and you have the active drug, which is ready to exert its actions. And I would like to present the two major studies which led also to the approval of this drug. This is the Path Forward study and the Pathway study. Starting with a Pathway, this was a phase 3 trial, which in the first double-blind period, they had 26 weeks of using palopeg-teriparatide, 18 micrograms a day, or placebo. And then this was then followed by an open label extension phase. And you can see here that their efficacy endpoints were, of course, the normalization of biochemistry, and of course patients were independent of conventional therapy, but they also looked into these long-term complications we talked about, so renal and also quality of life and also safety aspects. So coming now to efficacy, as you can appreciate, it was an efficacious drug because nearly 96% of the participants did achieve this independence from conventional therapy. And this is what happened to the biochemistry, so serum calcium and serum phosphate. As you can appreciate, here's the first double-blind period, and here the extension phase. So this shows that during the first phase, but also the extension, both parameters also reached a steady state within the normal range. So the renal aspect was something of great interest, and here they also tried to decipher if there would be differences between patients that started with impaired renal function, which was defined here as GFR lower than 60, or better renal function. Here you can appreciate, especially in this first period of treatment, the increase of GFR. And what is of interest, I think, that it is more prominent in patients that started already in phases of renal insufficiency. And this is also shown here. This is what they defined as a clinically meaningful increase of renal function. And this was more prominent in patients that started with this impaired renal function. We can discuss about the pathophysiology of this. One of the ideas is that, of course, this renal impairment has to do with hypercalciuria in patients with chronic hypoparathyroidism, and here you can appreciate also through the normalization of the mean 24 urine calcium excretion, also through the open label phase. Quality of life is also another aspect. Just one slide about this. This is this HPS symptom physical domain score, and also impact daily life score. Just to be brief about this, so here to know that when one has a higher score, it means impaired quality of life, and here through the first phase, but also in this open label phase, you could see the lowering of the HPS scores, and also that they remained also stable during this treatment. Adverse events were also very well adjudicated. Also in this study, you can see the most prominently reported were injection site reactions, which is often the case with injectable drugs. And of course, some of these adverse events, one could also argue, were the part of the treatment, were the part of the disease. Yes. So coming now to this second trial, this was the Path Forward phase 2 trial. And here I want especially to highlight the skeletal aspects. This was a point that was also raised about patients with hypoparathyroidism and osteoporosis. So, as is well known, chronic hypoparathyroidism is a state of low bone turnover. So what one here can appreciate is that the bone resorption marker, CTX, and the bone formation marker, PO1NP, initially increased. So you can see also when they reach their peaks here at week 12, here week 26. But they remained above baseline levels through the trial period. And I think what is even more informative is maybe this slide, because here they wanted to present this as a fraction of the upper limit of normal. So what would you then consider to be a high bone resorption state, as we know, for example, from postmenopausal osteoporosis? And here you can see that they were only transiently elevated between this upper low normal, and then they remained below this, and this is of course also age and sex matched for these patients for this treatment period. And the other point that was mentioned was DEXA scan and BMD. So just here to show that at the initiation of this treatment, patients with hypoparathyroidism had high Z scores and T scores, even meaning plus 3 from Z scores, or from plus 1 standard deviations in T score. So they started, of course, at a high BMD level. And here you can appreciate that indeed through the treatment we had declines, but the declines were also very, very relevant to how the patients started, meaning that the patients that started with the highest T scores and Z scores were the ones that declined the most, and the ones that started with osteopenia, we can see here in this case we didn't have someone with severe osteoporosis, but the ones that started with osteopenia more or less readjusted, and it means to conclude that the skeleton readjusts to a state of a euparathyroid skeleton. So the main messages were, of course, that it had sustained efficacy in both of these long-term trials that I showed, that from this characteristically state of low bone turnover and maybe elevated BMD levels, that we have more age-appropriate physiological ranges. The renal data are very impressive to my mind. And of course, the aspect of quality of life, where we can discuss, of course, how to stratify and quantify this. And just another short introduction, because palopeg-teriparatide is not the only regimen or drug that is, of course, this is the one that has been approved, but there have been studies running also for other drugs. So, for example, this molecule here, the eneboparatide molecule, is a hybrid analog of PTH and PTH-RP, which also binds to the PT1 receptor, but also it remains bound to this R0 conformation, which has to do also with duration of treatment. And just to show, this has already been published from phase 2 trial of eneboparatide, that there was also a significant amount of patients coming here which gained independency from vitamin D, and also from their calcium supplements, and also here the first urine data that it does induce a rapid and profound normalization of urine calcium. And just to show that there are also 2 other molecules now in the pipeline. The one is this orally active small molecule against the PT1 receptor, and also coming now from the setting of another disease of ADH1, the calcium-sensitive antagonists, which this is based on this gain-of-function mutations of the calcium-sensing receptors. And this is already been well published for ADH1, but now there are trials for this molecule also for hypoparathyroidism. So coming now to the end, I think we can say that PTH treatment therapy is of course beneficial. These were the original preparations, teriparatide of course, and PTH184, which is not available anymore. Teriparatide, I hear, and I have discussed also with Portuguese colleagues, that sometimes it can be used in an off-label setting in the treatment of hypoparathyroidism. But coming now to palopeg-teriparatide, we saw the efficacy in terms of independency from conventional treatment, and also the very significant effects in terms of renal aspects, and also the this new steady state, the skeletal steady state, closer to age-appropriate norms in these adults with hypopara. Muito obrigada pela vossa atenção.
Thank you, Elena. Please come. So to ignite this discussion, I will kindly ask